Welcome once again to our webinar series, Rare Info series, where each day we talk about one rare genetic disorders, and we also speak on the management and different aspects of this rare genetic disorders. So today we have with us a topic which is right now a very hot topic. It's called Shattered Platelets and Struggling Kidneys, and we are going to sort of understand a bit into the HUS puzzle and unravel it a bit with the help of Dr. Alison Laptakma. Welcome, ma'am. Ma'am is a consultant and service head of pediatric nephrology, Hong Kong, Hong Kong Children's Hospital. She's the honorary clinical associate professor, Chinese University of Hong Kong and University of Hong Kong, President Hong Kong Pediatric Nephrology Society. And we also have with us our professor, Professor Rajiv Sinha, sir, who's again a senior pediatric nephrologist at Institute of Child Health. Without wasting much time, we would be starting our session. And over to you, Dr. Alison. Thank you.
Thank you so much. Can you hear me?
Yes, ma'am.
We can.
Thank you. So let me to the slide. Can you see my screen okay? Yep.
Yes,
all right.
ma'am.
Okay.
Yeah.
Thank you so much. Right. Thank you. Right. Thank you, Chairperson, for the very kind introduction. And of course, thank you, Rajiv, for inviting me to share with you on HUS in children today. So this is where I work. I work in Hong Kong, and hopefully we can meet face-to-face, and we'll show you around the new hospital. So in this coming 45 minutes or so, I hope to share with you about the overview of this very complex condition, hemolytic uremic syndrome in children, and hope that at the end of the session, I will bring more information to you rather than more confusion. So we'll be going from the nomenclature to the complements, the role of complements in HUS, diagnostic challenges and management strategies, and a way forward. So speaking of hemolytic uremic syndrome, so the term and defines that it's a syndrome that consists of hemolysis as well as uremia. So whatever the etiology is, it's a result of the pathological process of TMA, thrombotic microangiopathy. So HUS itself, it's a clinical triad of microangiopathic hemolytic anemia, thrombocytopenia, as well as organ injury, so especially acute kidney injury. So that's why nephrologists are particularly concerned. So we have to understand this complex disease because, number one, it appears not too uncommonly. So the real rare disease is the complement-mediated ones, but we see the TMA phenotype every now and then secondary to medical diseases or drugs or hypertension. And the other interesting thing with HUS is that it doesn't have to come into the triad, although classically it should be. Sometimes we see incomplete form and where patients can have TMA phenotype without having the full picture. So we have to have the clinical awareness and make sure that we recognize the pattern timely. So thrombotic microangiopathy is the common pathology of all etiologies of HUS, so which means the clotting of the vessels, arterioles or capillaries. So down in the endothelial cell level, we have detachment of the endothelial cells and also thickening and inflammation of the vessel wall. And resulting with the platelet thrombi causing the obstruction of the vessel lumen. So as a result of these clotting up the vessels, there are various different types of TMA syndromes that can happen, but not all of them is related to complement mediation. Some of them is related to, for example, TTP is one type of TMA syndromes. So sugar toxins, HUS is also another type of TMA syndrome. So this is a common pathology of many of the TMAs that we see. So regarding the classification, or we say the nomenclature, it has been changing over the years as we understand the disease more. So as we mentioned previously for TTP, which is one of the TMA syndromes, so which is defined by the deficiency of Adams 13 enzyme, it could be a congenital disease or acquired because of the presence of the antibodies. And for example, stack HUS, which is the most common by far H type of HUS, and it's defined by the presence of sugar toxin producing E. coli in the patients with HUS phenotype. So what is atypical HUS? Now, your typical or your atypical in your part of the world may not be my atypical or typical, so it is a rather confusing term. So most people would think that atypical HUS actually include a heterogeneous group of conditions Only some are mediated by complement pathway dysregulation or the presence of autoantibodies against factor H that results in this HUS phenotype. So it's really confusing because some experts will regard atypical HUS as just complement-mediated atypical HUS, but some would think that it's anything non-stack and anything non-TTP. So that's why even with the same term, they may carry different meaning. And that's the reason why a group of experts together around as the National Kidney Foundation Working Group recently and discussed about the terminologies. So the experts were gathered and they're trying to think about a better terminology so that we know exactly what we are talking about and there will be no confusion. But the key recommendations would be a more appropriate umbrella term instead of using the atypical HUS would be a TMA. And of course, it would be best to have a qualifier describing the underlying etiology when it's known or suspected. But of course, it doesn't solve every problem, and especially the drug complement inhibitors was approved by the FDA since 2011 with the diagnosis of atypical HUS. So a change in terminologies may have other implications as well, but it will be important to understand that the terminology or nomenclature has been changing over the years. So now, for clarity's sake, we would refer to complement-mediated atypical HUS as the disease that we are discussing today. So this is a truly rare disease and with the reported incidence of approximately 0.5 per million per year. And this is a disease that we care most because it carries significant morbidity and mortality. And without the event of complement inhibitors, 50% of patients can reach kidney failure in 5 years. And these patients tend to have high rates of recurrence in the kidney transplants with extrarenal manifestations. So that's why it's really important that we all recognize that early and manage that early. The most important challenge is how to tell between the primary complement-mediated atypical HUS with an infection trigger from secondary HUS that was related to other diseases. That would not be very easy all the time. So this is just a repeat of what I've just mentioned. So we can see from the earlier global registry, but this review does not contain every Asian countries as we understand. So where we have around 850 something patients, and of which 380 patients were children, we can see that more children than adults more children than adults remain to be free from kidney failure in 5 years. But the onset of adulthood, it's an independent risk factor for kidney failure. So you can see the adults in 5 years, 50% went to kidney failure. That was pre-eculizumab era. And children tend to do a little bit better, but it's still not the best. So now coming to the spectrum of TMA. So how do we classify this and so that we understand the disease better and make better diagnosis? So this is my favorite diagram from the Newcastle team, David Cavanagh's group. So we can say that TMA can be classified into primary, secondary, or infection associated. So when we talk about primary, so we can have acquired ones. So these are the diseases with presence of the antibodies. These are the ones with congenital inheritance. So we can see that the true rare disease is here, atypical HUS with complement gene variant, and also atypical HUS with factor H autoantibody. So these are the ones which we can regard as complement-mediated atypical HUS. So there are other causes of TMA which has an hereditary origin, so which can include TDP with Adams 13 mutation. This is not because of the complement, it's not related to complement dysregulation, but it's because of the deficiency of the Adams 13 enzyme. So, and also other causes such as DGKE, TMA, and also cobalamin C deficiency, like a metabolic disease here. And more recently, there are some RNA pathway syndromes, which are very rare as well. And these also can cause a TMA phenotype, but it's not because of the complement dysregulation. On the other hand, we have patients with secondary TMA, which I mentioned before. So these phenotypes happen because of other medical diseases like drugs or other situations that result in transient complement activation, which we'll come to that later on. And of course, a big group of infection-associated TMA on the other side. So knowing the classification and putting the patient into the right box would be very important in the diagnosis and subsequent management. So now let's take a look at the complement system and also the TMA. What is the relationship? So before that, let's have a look at the complement system. So we know that the innate complement system is part of the innate immunity that allows us to have rapid response when we are attacked by pathogens. So complement system can be activated by 3 pathways: the classical pathway, lectin, and alternative pathway. So we understand that the classical pathway is being activated by the immune complex, lectin, by the interactions with the bacterial pathogens, the cell wall, and the cells. an alternate pathway, which is basically a constitutively active or continuously active pathway that allows us to have rapid response. So the pathway on the alternative side, it's being tightly regulated by these regulators, which is the plasma proteins and some of the membrane factors. So all three pathways converge at the level of C3 at the amplification lobe. So, and then with the formation of the C3 convertase on the other side, it converts C3 into C3b, and then hence the further formation of the C5 convertases on the other side, and hence activation of the C5 and formation of the membrane attack complex. And we can see that if there is this dysregulation of the regulators, or if there are more activators that happen, this pathway will be very, very active, and there will be uncontrolled activations of this alternative pathway and resulting in formation of terminal attack complex, and which can result in pathology. So that would be the basics of the complement system right here. So now we understand that in complement-mediated atypical HUS, up to 60% of patients, we can find either a pathogenic variant on these complement genes, which could be a loss of function variants in regulatory proteins, namely the factor H, factor I, or membrane cofactor protein, or the gain of function of the mutations which result in activations, such as factor B and C3. And there are some patients who have autoantibodies against complement factor H. So, and that's one of the diagrams that shows you and a repeat of what I've just mentioned. So these are the regulators and the activators. And of course, there are a group of patients who may have the conversions of the genomic rearrangements and conversions involving complement factor H, CFHR1 and CFHR3 have also been demonstrated to cause complement-mediated atypical HUS. And of course, as mentioned, the presence, the homozygous deletion of the genes of CFHR1 and 3 and 4 are also associated with the formation of autoantibodies. So the inheritance is different according to the different mutations right here. So we can see that for, so if you look at the CFH, CD46, and CFI, also with the two activators mutations, they're mostly AD, so a heterozygous mutation can result in the disease, and they have got different numbers of the relapses rate. And so which, if we have time, we can go into it a little bit in details. But we understand that these are quite rare disease, and you can see the incidence goes from 0.6, 0.06, and all the way to down to this very, very, very rare disease. So it's really important to have the awareness. So this is just a summary of what I've just mentioned. It's all about the balance between complement regulation and the complement activation. So if there is, the system is dysregulated, there will be an unopposed formation of the membrane attack complex and hence the phenotype. So as far as we as nephrologists are concerned, the kidney diseases that are associated with complement pathway dysregulations mainly are the C3G, which today we probably don't have time to talk about, and also the TMA. It's a spectrum. So where in the C3G, we have the loss of control of the C3 activation, and most of them is in the flip phase and resulting in the systemic glomerulopathy. So whereas on the other hand, when you have the TMA as a result of the genetic mutations or the presence of autoantibodies, we have more like an overdrive to a terminal pathway and hence resulting in the cell lysis phenotype. So what happens is if somebody has a dysregulation of the alternative pathway, there will be uncontrolled terminal pathway activations and resulting in the endothelial cell damage and hence platelet activation, immune cell activation, and clotting of the vessels, and hence the TMA phenotype. So that's how we understand about this primary TMA. How about the secondaries? So we understand that there are actually a list of conditions, as we have mentioned, ranging from drugs, infections, autoimmune diseases, and all the way to malignancies and HSCTs, and nowadays also gene therapy. So where all these conditions, by a variety of mechanisms, can result in endothelial cell damage, and hence the direct damage to endothelial cells can result in the thrombus formation and secondary or we can call it transient complement activation as a result. So, and this is what we call second hit theory. We believe it's one of the potential mechanisms that can explain the secondary TMA phenotype here. And I would like to introduce to you about the concept and about endothelial glycocalyx, which is a very important integrated layer of matrix lining the luminal side of the endothelial cells, and is made up of proteoglycans, glycoproteins, glycosaminoglycans, and adherent plasma proteins. So this matrix is very important in the first barrier of the vascular wall on the luminal side of the blood vessels to maintain vascular homeostasis. And we understand this layer, which the main constituents is the heparin sulfate, and it's of the glycosaminoglycans, has a critical role in the vascular homeostasis because there are binding sites for the complement factor H and complement factor I. So, and it's important to see when in situations where there's injury of the glycocalyx and it can result in the complement dysregulation, just like what was recently it's also known to be hemolysis is also associated with the altered heparin sulfate, as we mentioned, and hence the disturbance of endothelial glycocalyx with the local complement activation. So these, we understand that glycocalyx plays a very important role potentially in the pathogenesis of secondary TMA. Another recent paper also showing that in the sugar toxin related HUS. So what happens was, so in sugar toxin, there were two main strains of E. coli sugar toxins here. And what happens is in a genetically engineered mouse, when there's GB3 expression in podocytes, you can see that was they examined the signaling changes, and it was concluded that a rapid reduction in the podocyte VEGF secretion led to the loss of this glycocalyx layer, and hence reduction in complement factor H binding and the resulting inactivation of terminal complement pathway. So the importance of the finding recently regarding glycocalyx is that could that be another potential way to inhibit terminal complement pathway activation by this model? So this is still a question that we want to answer. So, and of course, the glycocalyx theory may not be able to understand or explain all the pathogenesis of secondary TMA. For example, in HSCT, there are many other theories, including in NETs, and also a wide range of theories that are behind. And also the gene replacement therapy related TMA, they're actually much more complex, a lot of science behind. So there's still a lot unknown or a lot to be discovered regarding to the pathogenesis of various types of secondary TMA. So how about the diagnosis of treatment of the TMA? What should we do? So now let's go back to this spectrum and the diagram that we mentioned. So it's a very important fundamentals that we understand. So by putting the correct, putting a patient in the correct box will be very important to start with. So as I mentioned at the start, so the diagnosis of HUS is basically a clinical one. So most important is before we delve into the sophisticated complement tests, which are expensive and may not be available everywhere, it's important to do the basic tests and to have the suspicion first. So these will be all important at the baseline with the Adams 13 activity assessment, in the sugar toxin assessment in indicated cases. So remember, not every patient would have diarrhea. So diarrhea negative doesn't mean that it's not a stat case. And of course, we have to do urinalysis and the other basic tests. And of course, after that, we also can have a look at the complement testing. These are more basic ones. And if we have more available resources, we can go into the complement function assays and the genetic testing. But obviously, genetic testing is not always easy to interpret. So always discuss with the geneticist, especially when you're having something like a variance of a VUS that appears. So this comes from the most recent international, the ISN International HUS Forum report, and I think this is a very good list of tests that we should do at the non-complement investigations of TMA. And so it's always important to rule out secondary causes whenever we can before we dig ourselves into the sophisticated genetic tests or the complement studies. So this is a very handy diagram. Whenever we suspect a TMA, we confirm with the baseline test showing the MAHA, showing the kidney impairment, and of course the extent of injury, and assess the extrarenal organ involvement is important. We have to exclude TTP. Try our best to exclude the infection, but not always very easy, and exclude the secondaries whenever it's applicable. And if all these were excluded, and especially in patients with recurrent HUS and also with a positive family history, it will be important to go for a genetic test as well as specific complement assessment. So having your own protocol will be important. So regarding the biomarkers of atypical HUS disease activity, I have to say that there's no one good biomarker. So we understand that it's HUS associated complement abnormalities. So actually it results in the self-services. So checking the serum levels of C3 or even the serum level of the terminal complement complex C5b through 9 could be normal. So having a normal C3 and normal serum C5b through 9 does not rule out the diagnosis of atypical HUS, even during this acute disease state. So it's a very important point that we should all bear in mind. And we understand that, so there are some biomarkers of HUS disease activity ranging from the ingredients like the complement factors and all the way to the breakdown products, as well as the complement activation products, as well as the functional assays. But I have to say that there's no one good biomarkers at the end. So we can say that we have the lower levels of the complement proteins or the ingredients, and we have elevated levels of breakdown products. It's more likely that the patient is suffering from active HUS. And there are some more sophisticated tests. For example, here is the in vitro functional test quantifying the number of serum-induced C5b39 formation on specially treated human microvascular endothelial cells here. So this is to aim to show that the C5b39 formation in the cellular level. But of course, this very sophisticated test will be only available in specialized laboratory, and is meant to be very useful in detect complement dysregulation at the cell surface, and it differentiates between active disease as well as from the remission, and it would be very good to evaluate the effectiveness of eculizumab. But the use is still under investigations because of this very specialized lab is available, and also not every lab could have the repeated tests showing this similar results. So I guess it would be a very good potential test in the future monitoring. So now, talking about this inheritance, we understand that the risk of developing disease is, say, like in a family with familial HUS. So what is the risk of penetrance? We understand that in HUS is an incomplete penetrance. So we used to think that probably it's 50% before from the anecdotal sort of studies. But the recent review from the Italian group has shown that the risk of developing the disease in any relative of the patient carrying a complement gene is only about 20%. So the penetrance will be higher depending on which mutations that the patient is carrying. For example, in the CFH, C3, as well as the hybrid genes, but it's lower in complement factor I. So it will be very important when we're trying to counsel the parents and counsel the siblings, and we understand that the penetrance may be higher in the siblings and also offspring compared to that of the parents. So now coming to this management of TMA as a general principle, it will be very important to have organ support, and the course should be directed. So for example, if the patient was suffering from TTP, obviously will be the plasma exchange. And with secondary TMA, we have to treat the cause and support the patients. But if the patient is suffering from complement-mediated atypical HUS, then we would be more targeted to make use of the C5 inhibitors. And the duration of treatment has been controversial for a long time, so we'll be coming to that in a second. And for acquired causes like the presence of anti-factor H antibody, that will be another treatment algorithm that we can share. So for complement-mediated TMA, so anti-complement therapy has been licensed, as mentioned, since 2011, so which is a first-line therapy for complement-mediated HUS, but unfortunately, this drug is very expensive, and its action is to bind to complement C5 and preventing the cleavage from C5a to C5b, and hence prevention of the membrane complex type complex. And the ravulizumab is a long-acting type of anti-complement therapy that has been used in children and is proven to be quite safe as well with a similar efficacy. So the current practice, especially in children, is that if we have eculizumab available in most cases, if we have a suspicion of atypical HUS, probably eculizumab would be the first line. But since we've mentioned in the resource, it's a very expensive drug and may not be available in every country. So supportive care and the role of plasma exchange has been discussed, and especially the role of the plasma exchange and role of anti-factor H, Hemolytic Uremic Syndrome would be very important as well. So this is one of the recent review from the Newcastle group, and which shows that in eculizumab resulted in significantly improved 5-year end-stage kidney disease-free survival in complement-associated HUS. You can see that. And the response of obviously depending on which type of mutation that we are having. So if the patient is having XYC3, which is a novel, a non-complement cause of HUS, so the use of eculizumab would not be useful. And it's also important to see that how do we define a success of eculizumab or response to eculizumab. So usually we expect the platelet normalization to be within the first week. So in here in the review is commenting around 4 days. And the major renal recovery usually happens, if any, within the 30 days, but it can be ongoing response up to 1 year. But it's also important to remember that eculizumab does not, it's not without complications. So it's also increased there's much higher risk of meningococcal infection despite the vaccination and antibiotic prophylaxis. So it will be important to think about withdrawal even if we start the patients and on this drug, which is usually very useful in complement-mediated HUS in most of the cases, but it doesn't mean that the patient has to carry this drug on forever. So there are indications of withdrawal that which will come to that later on. So now when we come to this, the duration of anticoagulant therapy, the trend is to consider more restrictive use except in high-risk mutations or special situations. So that was one of the hallmark study back in 2021 by the French group. So where the treatment discontinuation, it really depends on which genetic defect the patient is having, and it also is associated with the risk of the recurrence. So in this study, which is a prospective national study in France, where 19 children out of the 53 patients being included with a treatment duration of around 16.5 months, we can see around 23% of the patients develop a relapse after treatment. So, and risk factor of the relapse include female sex, the presence of a genetic variant, and of course, if the patient seems to having elevated serum C5b39 levels at the time of the discontinuation. But we can see that actually with these patients, even if they develop relapse, if they're being picked up early enough, and with the C5 inhibitors being instituted again, so actually the outcome would still be very good. So eculizumab discontinuation was reasonable and safe and improved management in quality of life and also reduced the cost. So that was from the Stop Ecu study back in 2021. So, and after that, the Dutch group in 1 year later also made a similar conclusion with the prospective observational studies with around 21 patients, not a big number, but a very similar relapse rate of 22%. And we can see that it's also agreed that all relapses, if being picked up better, so the patients can actually have a pretty good prognosis, and it also agreed with the cost reduction of 70%, and the eculizumab withdrawal does not affect the quality of life negatively. So that's why with the major studies around the world, we see that the trend, even though if the patients carry the genes, it doesn't mean that the patients will always have this HUS, they will always carry the risk of HUS, but it doesn't mean that the patient would need to have complement inhibition all the time. So it's possible to discontinue the drug, provided that adequate surveillance is being done and timely reinstitution of treatment is available. So that is the important message. So anti-platelet antibody-mediated TMA, of course, there are two particular sort of lines of thought. So we have one school of thought using the plasma exchange and immunosuppression versus the complement inhibitors blockade and also immunosuppression as well. But at the end of the day, the treatment goal is to reduce the anti-platelet antibodies titer and to keep this titer low and hope to have a lower relapse. So probably today we won't spend too much time to talk about that. But I think in India, Professor Bhaga and Professor Sinha, they have done a lot of work on this anti-platelet antibody, and the expertise is very much respected. So now what is the future direction of TMA here? So we understand that prototypically, the rare disease, if the complement dysfunction has a primary role, for example, in primary atypical HUS and diseases like C3G or primary IC-MPGN, we understand that the potential impact of complement inhibition would be higher. But whereas, like, as we go along the spectrum, if we have other diseases with probably transient activation of the complements or the complement role, it's a secondary, then we probably have to think about and think twice whether or not the use of this eculizumab or the use of complement inhibitors are really, really useful, because primarily complement dysfunction is only a secondary driver of injury. So, and you understand that nowadays we have a lot of different trials using complement inhibitors in kidney diseases, not limited to C3G and not limited to HUS, but also a wide range of glomerulonephritis, including lupus nephritis and all the rest, and ANCA and all the rest. So it's been a very, very fast growing area with lots of interesting findings as well. So nowadays, apart from the eculizumab as well as the eculizumab we mentioned, we have other C5 inhibitors like crovalimab, and also we have the C3 inhibitors and prisacticoliban here, which is also very promising in the C3G. We also have the iptacopan on against infected B. Again, C3G has been a very vibrant studies and ongoing, and also the drugs against infected D, and here against the MBL pathway, nasoplimab. So there are actually many new things coming out, and of course, like all these therapies, the one thing is that it's not available to every country, and most of them are very expensive. And not to forget about the fact that it's also effective in the in many of the vasculitis and also complement-mediated conditions as well. But this is not the end. Despite a very vibrant development and very active research area, we understand that HUS, after all, it's a very uncommon disease. And especially when we are talking about this complement mediated atypical HUS. And randomized control trial, it's not possible most of the time, and very costly drugs. And we need to refine our international consensus. And there are also other pathogenesis of atypical HUS and TMA. So this diagram just summarizes the non-complement mediated etiologies of the TMAs. So as mentioned, there are some RNA pathways dysfunction and all the rest. So these are very interesting findings. And so complement is only playing part of the role. So beware. So maybe in your patients with very different pathology, a very different phenotype, you may have some new finding as well, and it's good to share with the global platform. So, this is, I'm coming to the end of my talk. So some of the references and most would come from this really nice article that we have discussed in the International Forum recently. So I would really recommend you to take a look at this wonderful sharing over here with lots of useful information. And so last but not least, I would like to thank my mentor, Professor Christoph Licht, and my wonderful team at Down Country Hospital, and my patients, parents, and as well as the wonderful group of friends who are very passionate about atypical HUS. And so thank you very much for your attention.
Thank you very much. That was a really comprehensive talk of this huge subject, and and actually, as we all know, that we still don't know many of the points, and the every years, or in fact, I think it is much more fast that something new is coming up, and it's very difficult to keep in touch. In India at the moment, we are excited because hopefully we will be having eculizumab available, maybe in a month or so. We still don't know how much will be the cost will be, and we are excited, but at the same time we are also a bit worried because what will be the use of it? Whether there is always this concern about whether there will be an inappropriate use of it also. So all of these things has to be clarified, and I'm sure lot of work is going into it, to make it its use more appropriate. I'll see whether we have any questions. I have got few from many of my colleagues have WhatsApp me few questions, so we'll start with that.
Yeah, sure.
So one of the question was that you have covered it, but then a bit with the Indian perspective in mind. Like once you have say diagnosed the cases and HUS, and suppose we know it is say complement factor H deficiency, and we have suppose we have been good enough to start eculizumab also. How do you monitor them up?
So the question is about the management
Monitoring.
of the
The
monitoring. So
monitoring, because you have to remember that in India at the moment we are not having any complement factor H activity level. That is not possible.
Yeah. So it's a very good question, Rajiv. So what happens is actually for anti-factor H antibodies and mediated HUS, so it will be the antibody, the clinical profile will be important. The clinical profile would be important. And of course,
Alison, this is not related to antibody factor H antibody.
Okay.
We'll come to that later on. This is where we haven't been able to find out any antibody.
Yes. So you're asking Yeah.
Then once the eculizumab is started, how do you monitor them up?
So this is so what sort of the pathology is that? So you mean
Fac
it's
Factor H, say factor H mutation?
so it's the factor H, but it's not the antibody ones, right? So it's
No,
not
no,
the factor H,
no.
but it's just the factor
Yeah,
H mutations, what you're
yeah,
trying to say, right?
yeah,
Yeah.
yeah.
So I guess like yeah, it's a good question. So what we usually do is in the first place when we institute eculizumab or C5 inhibitors, so we look at the clinical picture. Yeah, so most
Mm-hmm.
important is the clinical response, and as indicated by the resolution of protein urea and the improvement of kidney function, and of course the complete blood picture recovery. Yeah, so that would be very important. And of course, then we want to make sure that the eculizumab level is adequate. And if we have the complement factor, the complement assays into as to complement function assays will be also important to see like whether or not the complement system of the patient is completely suppressed, and that correlates with the clinical quiescence of the disease. So this is what we do. So,
So,
and obviously, yeah.
which complement function assay do you look at?
Mm,
CH50, or do you look
yeah,
for the
yeah.
specifically for?
Yes. So we would, yeah, definitely. So it's correctly mentioned. It depends on what the laboratory is having in like individual labs. So, but they complement function assays, including CH50, AH50, as well as the soluble C5b through 9. So will be important. So as sort of like giving you a clue about like how where we are in terms of the complement suppression. So I guess like this is all serum levels, as I mentioned to you, may not be as specific to the cellular sort of like breakdown product, showing that the disappearance of the soluble C5b39 in the cells. But as we mentioned, that the cellular ones or the in vitro ones are not available in every country, and it's only available in experimental labs. So the more available ones will be the complement functional assays that we usually check on, and most important is the clinical response of the patient. Yeah. So and so what I'm trying to say is that probably before a few years, it has a lot of development in the recent few years where the complement inhibitors, we are thinking about discontinuation rather than a lifelong continuation. And because there are many new trials and studies showing that it's actually possible to discontinue those drugs. But most important is to have very close monitoring after discontinuation, and if necessary, reinstitute the drug timely. So that would be my answer to your question.
So once the eculizumab is available in India, so you feel then it will be very important to have this monitoring kits also, like
Yeah. Mm, mm.
and
Yeah.
in Hong Kong you have got
Mm.
all of them, like including the uh, member, like MSc level also.
We what said again? I
In
can't catch.
in Hong Kong,
Yeah.
you have got all of this available with you, like a CH50, H50, and the membrane at a complex levels. You have
Oh
it
yeah.
available.
We have the H50, CH50, as well as the soluble C5b through 9, but we do not have the HMAC assay. So we don't have the in vitro functional assays of the HMAC. We don't have that. Yeah. Yeah.
Okay.
So it would be pretty much like a combination of everything. Yeah. Not easy. So because I guess like these are rare disease and it takes a long time to develop all these things. Yeah, but it would be very exciting to have this eculizumab coming to India, and hopefully I hope the price will be more reasonable because it's still very expensive in most parts of the
Yeah,
world. Yeah.
yeah.
Which
And
limits
any
mm.
and any comment on on using this without the availability of this level? Like
Mm.
suppose we don't have this, like we
Mm.
can, as far as I know, we can do CH50 and AH50
Mm.
in some labs in India.
Yeah. Yeah.
The C5B, that is not
Mm.
available at the moment. So
Yeah. Yeah.
any comment on like in that sort of a situation, how you can, like, what do you advise?
Mm. Yeah, I think what happens is this we can only make use of what we have, right? So what happens is like even without those, I think the most important thing is to remember to vaccinate your patients and to watch out for complications in the first place, and of course monitor the clinical response even without all these things. So if like the patient is responding or not responding, that would be a very important judgment. The reason why I say that is, remember I showed the slide that if the patient is responding to your treatment, the complete picture usually responds within the first week, and the renal recovery usually within the first like 30 days. Of course, some patients would take longer. The only question is if we do not have these adjunctive tests, including the eculizumab level or including this like CH50, H50, and all the rest, we do not know if the drugs that we are using is already adequately suppressing the disease. Adequately suppressing the complement system or not. You see what I mean? So like if the patient is having this condition, this is not improving, is it because our drug dosage is not enough? Or is it because it's already enough, but then it's on the wrong direction? Then we should not be using these C5 inhibitors. You see what I'm saying?
Yeah,
So
yeah,
what I
yeah,
usually,
definitely.
so I think the most important part is right here. So it's if we have the availability of these tests will be more sort of like a conjunctive and telling us, okay, now we have everything suppressed, and if the patient is responding, that's very good. But if we do not have the complement system being suppressed and this patient is still having disease, that means the drugs needs to be intensified or dosage needs to be adjusted. So I guess that is one of the important points that we can take into consideration. But of course, I mean, we can only do with what we have. And it's really kind of challenging, but the clinical bit would be most important. Assessment will be most important.
So then, like if I can summarize, like if there is a clinical response, then maybe we can get away from doing this test more frequently. But if there is a poor clinical response, then you are mainly in trouble.
Yeah, I think that would be one of the interpretations as well, and it's very reasonable given that these tests are very specialized and it's not available everywhere, so we can just do what we have and deal with what we can.
My next question was like what you were starting with, the antibody mediated complement factor H. How frequently do you see that in Hong Kong?
No,
And your practice, like if you see them, what is your practice like? Do you still use eculizumab or you go for the plasmapheresis and immunosuppression? Because in India, we see antibody mediated thing much more frequently than the other forms.
Yes, it's a great question, Rajiv. I would say like anti-factor antibody HUS, the Indian experts are real experts. So I can see the incidence of finding it in children is actually up to 50-60% according to the reviews from Professor Berger and his team. So I cannot claim that I'm an expert at all. But what happens is we don't see that very frequently. But one of the reasons is because we have not been checking it. So I would say that for the past 10 years, we only have this anti-factor H antibody assay. The factor H antibody assay is recently available for the past few years. So we have not been checking this regularly. So I think it's the reason why it was not picked up. But now that we have the assay in place, and it needs a lot of titrations and comparison right now with the national labs and all that. I think that would also increase the pickup rate. So, I mean, if given that we have a case, so recently we did have we have a case. So what we did was with eculizumab, and it works really well.
And this assay that you are having, is it a ELISA based lab assay or like something? Okay.
Yeah. So I can send you more information after the talk and connect you with the immunologist and all that.
No, we are also like in India, there are two places which are mainly doing this antibody. One is in KEM Pune and one is in obviously Dr. Baggas's lab. So AIMS are using, they've developed their own thing, whereas the KM, I believe, are using the ELISA based lab assay. And for us, it is like that is another big question that needs to be answered by the expert, that in antibody mediated HUS, whether you should be first giving eculizumab or you should be starting with plasmapheresis and immunosuppression, and if it doesn't work, then go for eculizumab.
Yeah, I mean, like there's more that's good evidence that eculizumab works quite well, so I have to say. But of course, since this drug is not widely available yet, and we can see very good results also from the from your country with the use of a plasma exchanges as well. So I guess like that's the reason why when I talk about the anti-factor antibody, the management would be on the two sides. So either way it would be working. But obviously, if the patient has we have eculizumab available, it would be working quite well as well. Yeah.
Dr. Dipanjana, do you have any specific question? Because I had one related to genetics also. But if you can, hello, Dr. Dipanjana, you
Uh,
have any question? Yeah.
Yes, sir. Sir, I have one specific question that when we are looking for these particular sets, they are more segmental duplications in these regions. And as a result of which, we get a lot of rearrangements related to this, which we probably can also be a basis in the population. So, my first question would be, in your country, do you really have a basis of these, like a known factor of these, what are common segmental deletions or duplications in your population? And second, if you don't, then how do you interpret these reports? Because many of them are very overlapping and very common in the population. Then how are we doing an association of these deletion duplications with the with itself the disease?
So because I'm not a geneticist, so what happens is like every time when you get a report and with a patient with suspected atypical HUS, we always discuss with the geneticists on their views. So you're right, like some of those mutations and they could be present in normal population, right? And the patients may not have any symptoms at all. So it really depends on the clinical phenotype and the exact type of the mutations, whether or not, and we have to curate every gene that we see and see whether or not it's related. So yeah, that's true. It's always a challenge. So we also got like a consultations like from someone who has a kidney failure with like another type of nephropathy coming in with the homozygous deletions of the CFHR proteins, CFHR1 and CFHR3. So does it mean anything? So we got a consultation from surgeons and talking about, what is the recurrence of HUS? But this patient never had a HUS in the first place. So there's no need to worry. And those are very ice cold VUS, and probably it does not really matter. So you have brought out a very important point indeed, is about, when we find something from the genetic side, is it related to the patient or not? So it has to be a joint discussion. And of course, the phenotype would also tell us a lot as well.
So
That
in these
should
cases, do
that
you
should
do
make
family?
Dipanjana happy, because like involving geneticist, I think
Yeah,
that is
yes.
a message that
I
she
think
wanted
Ratna
to
ma'am
also
has
say.
joined the. I think Ratna ma'am probably had joined the conversation, like this meeting. I don't know if she is still there. She has left.
So
Uh,
the other
but
thing,
yeah,
it's a if I may also share, like because there are other than the complement related genes, we also have the non-complement related ones as well. So many times we're very desperate in trying to find something to explain the TMA phenotype in our patient. So it's very easy to attribute this new finding or novel finding of a gene to this disease phenotype, and this also very risky. So many times whenever we're seeing this, we always involve the geneticists and discuss, and many times we may need to have the functional analysis and to confirm that, this so-called novel gene mutation is actually making a difference in this patient, and hence with the relationship, which is causal relationship to a TMA phenotype. So I would say like TMA is a very, very complex and intriguing disease. And of course, just nephrologist is not enough. That would be my final answer.
so my reflex question to this would be, number one, if you find such things, do you actually do a family studies also, the normal ones, like what is the trend? And my second would be that, is there any need to do a genetic study as far as this particular, because I know Alport, nephropathy, or nephrolithiasis, nephrotic syndrome, we do have a genetic basis and we have kept genetic first. But in this particular case, is there a genetic yield is very poor and understanding is also very poor? So do you really feel that there should be a genetic testing associated with these conditions?
So it depends on what we are talking about. So if we have usually when we have a familial, like say if it runs in a family, is like say if we have a child with recurrent HUS and it runs in a family, we have a few families in Hong Kong right now with that. So we'll do a family studies, definitely. And we analyze the results and see whether or not it's like a de novo mutations or it's like a really running a family, and like many times like we cannot, but it's very interesting that we don't we not every patient would have a complement gene mutations, and the finding of a non-complement gene mutations leading to a TMA would be a challenge. So you have to explain why it happens. And could that be not a secondary TMA, or could that be a real like new pathogenesis you're trying to discover? So many times for these patients, we would involve the scientists as well in trying to like see into that particular gene, what is the product from that gene, and go from the functional studies and to make a relationship. So obviously this retrospective analysis would also be in a way biased. So we have to be very careful when interpreting. Yeah. So this is what we usually do.
So, if I may intervene, in India, we usually have a low index for doing the genetics, particularly if the complement factor H antibody is negative, because we are unable to do the factor H level, factor I. All those things are not available to us, so we often go by the genetics, and because if that comes positive, but one of the main problem that we have seen is with this complement factor H related protein, because as you know, like it is quite common even in normal population, and when we do the genetics, that comes positive, and often there are experts like nephrologists, etc., who are who have even denied the further transplantation, because like your complement factor H related protein is positive, so you are highly at risk of relapse. Whereas, so would you like to comment on that?
Yeah, so the education and discussion with the adult nephrologist is very, very important. I have to say, like many times, the complement-mediated diseases are usually the areas of pediatric nephrologists rather than the adult ones. But of course, like I guess with the discussion and telling them about the the discrepancies about like finding no discrepancies, but you know what I mean, you can find something, but it could be very common. Like the variant can be very common in a population. We cannot say that it's a disease causing ones many times. And so it also depends on the phenotype of your patients. So as I just mentioned, like we do have patients with some other nephropathies, but then with the CFHR3 and 1 homozygous deletion. But he has never had this phenotype of atypical HUS, so we cannot say this, that he is in particular risk of that. And so seeing into the mutation and the variant deeply and discuss with the geneticists would be very important. At the end of the day, the variant could be an ice cold VUS instead of like a red hot ones. And so the recurrence risk, or as you said, like especially in the perspective of transplant, would be more relieving and more reassuring for the adult nephrologist. So that would be my short answer.
Yeah, Dr. Dipanjana, do you want to comment on this about the complement factor H related protein?
Comment in the sense that I feel our understanding as far as the genetics of this entire thing is very complicated, because it's also a combination of what the other recombinants are and then we are saying. So I don't know, I would believe on the clinical aspect as far as my interpretations are going when I'm analyzing this, but I don't know if there is any other way these could be interpreted, because we what we face in India, like when I'm working with sir also, maximum times when these we get these reports, it is also very prevalent in the normal population. And to actually distinguish that this is affecting the protein, or if there is a change and that will have a protein which will affect it in a different way, will have a different kind of response in a diseased person, is very difficult to establish as far as the pathology is concerned. So in this case, I would say we would depend on clinics only to explain. And even sometimes doing a like family studies, the experience is that probably that's also becomes inconclusive in certain cases in these analysis.
And
Yes, completely agree. Yeah.
yes, so we still have a lot to know. Oh, one more, there was one more question, but I think you have already answered quite a part of it. Like how do you decide on stopping the eculizumab? Like any particular time and any particular test? You have answered it a bit, but still, if you want, we can briefly on it.
Yeah, so so we are going to have the publication of the pediatric IPNA guideline on the atypical HUS management. So I would say that the consensus is probably we continue with the complement therapy for at least 3 months. So 3 to 6 months would be the window. So that would be the kind of consensus. And of course, it depends on the patient's condition as well. So in general, the trend is to if the patient responds really well to the therapy with complete resolution of the symptoms, and also as we talk about the biochemically and also hematologically and clinically. So, and we see that the disease has gone into quiescence. So we would recommend that the patient can be discontinued and most of the patients can be discontinued, or at least trial of the discontinuation after 3 to 6 months of the treatment. So of course, it depends if the patient was already having a challenge kidney function, or if this is a high-risk mutation like a complement factor H1 with a transplant on board, then discontinuation is probably very high risk and it may not be recommended. So it's really by case discussion. So I guess the evidence is pointing towards a more limited use of the eculizumab, even in most patients with complement gene variants and anti-factor H antibodies as well. But obviously, it depends on, there's always a risk. So as I mentioned to you, right, 23% of patients may have recurrence, and the Newcastle data, which is also coming out, I think the figure is a little bit lower. It's 18% instead of 22 to 23. So it seems that there is a certain percentage of patients that will still recur, this, whatever you do. But then the timely institution of the eculizumab would also do the trick. But of course, I think it's also important to mention to the parents before we discontinue those drugs, especially in high-risk mutations, and probably not to try in those too high-risk or with transplants and all that. So that would be also subjected to the clinical judgment. Yeah. These are complex decisions, but I hope that we'll come to get to the gist of that very soon. Yeah.
And for secondary TMA, do you use eculizumab?
Well, it's a million-dollar question, Rajiv. So there has been a lot of reports on the success in certain conditions. So especially, for example, in BMTs, Jadel and the team, so had a lot of publications, and in hypertension, and especially also in the autoimmune diseases, and in particular with the with those catastrophic lupus anticoagulant, the antiphospholipid syndrome, what I'm trying to say, and also in pregnancy as well. So it depends on what we are talking about. But the thing is, eculizumab is not funded by the public setting in Hong Kong. So for secondary TMA, so if the patients have indications of using it, it's by the clinician's judgment, and it has to be privately funded. So I think this is also the case in many and most developed countries. So even though we have certain evidence that probably eculizumab is useful in some of the diseases entities, especially if it's being used early, and most of these countries do not fund the secondary TMA, the use of eculizumab in secondary TMA. So it would be a challenge. But I believe that eculizumab may be useful in some of those, but we cannot make regular recommendations to all of these conditions, because after all, it's a heterogeneous group, and there are many factors, as I show you on the slide, that actually more than one factors that can cause endothelial injury, and complement dysregulation is only probably playing a small part. So targeting on that small part may help a little bit in some patients, but may not. We cannot generalize this principle to all. But personally, I believe that in certain patients, the use of eculizumab may be beneficial, especially if they are, very difficult and refractory to other treatments. Yeah.
Okay, so I think we are almost at the end of the session. I still have one more question from my side only, and it is from our institute, Institute of Child Health. We are at the moment dealing with something which we are finding it very difficult to understand. We have this child with MCP mutation, membrane cofactor protein, and we all know that it is supposed to be one of the better mutation to have. And this child is now under our follow-up for about 3 years. Initially when he came, he did require hemodialysis, and because we did not know the etiology, he underwent few plasmapheresis. Then once we knew the etiology, we stopped the plasmapheresis. His creatinine did come down, and he went to a CKD stage 1 or stage 2. But what he's having is a very, very severe hypertension. He's continuing to have about needing about 5 to 7 antihypertensives. And whenever the compliance dips, he comes to our emergency fitting with a hypertensive encephalopathy. Over 2 years, his creatinine is more or less the same. It hasn't gone up. It's about in milligram per deciliter, it's about zero 0.8, 0.9, 1.1. We have done a biopsy also recently. Biopsy showed it is a chronic TMA, but his LDH borderline, like it's not that he has been relapsing, but this persistent hypertension has been oh, is been there. So do you have any sort of experience like this or any idea on the MCP?
Yeah, so it's a very interesting case when you also have a very similar case presentations with the background of, but not MCP, with the background of the TMA due to other sorts of mutations, but the patients have very difficult hypertension. So, but your patient is interesting because he's actually in an early stage of CKD and instead of going to dialysis or really advanced stages of that as well. So, the straight answer is like, short answer is that when is the hypertension persistent? So if it's persistent or it's episodic, because what we found in one of our patients,
It is persistent. It is persistent.
yeah,
And usually, what happens, like for any of us, taking 7 to 8 medication is difficult. So when they go home after few months, I think he and the parents also forget the bad time, and they start missing few medicines, and the child start taking salt more, and then he comes back to the emergency with. So the last time he came, he had a blood pressure of 240 over 180 or something like that.
This is really interesting. Like, so whether or not this is a TMA attack that result in, so is the it's a cause or the result. So is it because that there is like a organ specific sort of acute TMA that happens and it doesn't show on the blood smear, and that's why he has this persistent sort of TMA. So because the renal biopsy was done recently, but then I
Yeah,
think that the child has been having this for a period of time. Is that right? So whether or not this is actually has been, recurrent TMA attacks and results in all these things is difficult to say. And on the other hand, when he has sustained hypertension, it can also trigger off the TMA as a secondary cause. So it's,
exactly.
a
Yeah,
vicious cycle. Very difficult to tell, but it's a very wise to do a kidney biopsy. And of course, if we have, other adjunctive tests, we can see whether or not there is like active depositions of these soluble C5b39 in the kidney, and then we can know more. But
we
it's
didn't have
difficult.
it just came
Yeah.
back as a sort of I in fact in
Yeah.
the IPNA I discussed this with Martin also, Martin Bidgen, and he was
Yeah.
of the opinion that you should be going for a nephrectomy, and
Yeah. Yeah.
doing a nephrectomy on a child who is producing good amount of urine, not on dialysis, is very
Yeah.
difficult. But then
Very
in
difficult.
the literature, there is 1 or 2 case reports of MCP requiring literature. But then,
But yeah.
case report, anything can happen in a case report.
Yeah, because we did nephrectomy actually, not on this SB, but we do have patients with atypical HUS recurrent, and then at the end of the day they have, but that child they had, he has already lost of the full kidney function, no more kidney
Yeah,
function, so we did nephrectomy, and there's no effector organ to contribute to the hypertension, so that's why we go for the nephrectomy in those cases. But in your case, because of a reasonable good kidney function, it would be very difficult to justify, in my opinion, to remove the kidneys at this juncture, but rather, of course, like we have to think about whether or not the treatments. I have no idea because like this patient has not been given like a continuous treatment of the of TMA, so
no,
to
I
speak,
mean,
right?
we haven't
Yeah,
given anything because
yeah,
eculizumab
yeah,
is not available
yeah. So I mean,
freely,
if
and
sure,
they can't
yeah.
afford anything from outside. So
Understand, yeah. So what I'm trying to say, if we have eculizumab soon in India, and it probably that
then
may
it
be the
may,
way to go. It may be the way to go, and we can hopefully see that the patient may be reverting to better blood pressure control as well as the kidney function. This would be the hope, because I have a feeling that this patient with the MCP mutations and with all these persistent symptoms of like hypertension and kidney impairment, there must be something going on low grade. I believe it's a
sure,
TMA
yeah.
manifestation.
Mm.
So I think that taking away the kidneys may not be, some physicians may think that way, but I would prefer not to before we have instituted the eculizumab, to help try to help this patient and see into the effect. That would be my humble opinion. I hope your child gets better.
Thank you very much.
Thank you.
For me, I learned a lot, and
Thank you.
yes, we also hope that you will be too in Calcutta soon. And I'd also like to thank the Organization for Rare Disease India for organizing this series of, like, we are having 4 or 5 talk focusing on rare renal disease. Idea was that to sort of highlight that yes, kidney can also have rare diseases. Dipanjana, do you have anything to add?
Just thank you so much. It was such a great learning and such beautiful. The presentation was such a crisp, nice presentation. It was like a classroom. So thank you so much,
Thank you.
and thank and hope to see you in Calcutta very soon. So thank you, Professor Rajiv Sinha sir, for giving us an opportunity to host such a beautiful series, and Organization of Rare Disease India for always providing us the platform, and also staying in the commitment of actually spreading the knowledge. So we have another series coming up on next Saturday, and that is Dr. Mani, who will be speaking on sudden cardiac death. So stay tuned, whoever has joined today. If you're interested in cardiogenetics, we are parallelly having alternate day session on nephrology and cardiology. So our next session will be back to cardiology, and we will be speaking on sudden cardiac death, being presented by Dr. Mani, who will be presenting on how to detect the genetics part and the management part, and very like brief notes on certain rare genetic disorders and their management as to how what is happening in their center. So stay tuned next Saturday, 4 p.m., same time, and hope you have a great weekend. Thank you all.
Bye. Thank you so
Thank you
much.
very much. Bye.
Thank
Bye.
you. Bye.